Hi, I'm Yoshihide Kanno from Sendai City Medical Center in Sendai, which is in the northeastern area of Japan. I am pleased to describe our article published in Gastrointestinal Endoscopy in this video. The title is very long, Efficacy of EUS-guided Celiac plexus neurolysis compared with medication alone for unresectable pancreatic cancer in the oxycodone fentanyl era, a prospective randomized controlled study. We conducted an RCT to evaluate the efficacy of EUS-guided celiac plexus neurolysis or EUS-CPN. EUS-CPN has been reported to be effective for patients with upper abdominal pain due to malignancy, but it has been unclear whether EUS-CPN is recommended or not, or in other words, whether EUS-CPN should be performed or not for all patients with pain. There have been several RCTs involving CPN without US guidance, but just a few with US guided CPN. In most of previous studies on US CPN, only single-arm outcomes or outcomes of a modified technique compared with a traditional technique have been evaluated. To debate the value of US CPN itself, studies comparing outcomes with and without intervention should be referenced. However, there has been only one study conducted in such a way. Let me outline the sole well-designed landmark study by Dr. WYSE'S et al. Reported in 2011. For patients with painful pancreatic cancer, the average pain scale at 3 months was significantly lower in the group in which USCPN was performed than that in the control group without USCPN with a p-value of 0.001. Apparently, this outcome validates EUS-CPN performance for all patients without contraindications. However, I feel that there were several concerns needing more study. In this study, it is unknown what kind of painkillers were used for patients. In addition, given the pain intensity which did not decrease from the baseline in the control patients, the amount of medication appears to be insufficient. They wrote that their patient population located in Montreal, Canada, was unable to be present for frequent follow-ups at the clinic and that the telephone survey was conducted, meaning that the opioid dosage could not be properly and timely adjusted by doctors. USCPN might be valuable in this setting, but not in another setting. In our study, which was conducted in Japan, where we could take advantage of the Japanese insurance system and the geographical proximity, patients frequently visited the outpatient clinic so that we could evaluate their pain level and adjust the opioid dosage. In this setting, USCPN was not found to provide significant benefits. USCPN necessitates full informed consent short but near prolonged hospitalization, physical stress, potential adverse events, and uncertainty in effectiveness, all of which were not or less frequently accompanied by opioid prescription. In daily practice, most physicians feel it is cumbersome to explain new intervention in terms of costs and risks instead of truly effective drugs which will be necessary in the future whether or not EUS-CPN is performed. On the other hand, outcomes might be dictated by methodology for pain control, which has been developing nowadays. New opioid drugs such as oxycodone and fentanyl have emerged with less adverse effects. These drugs have been developed with various formulations such as sustained release and rapid-acting preparations for oral, sublingual, suppository, or injection administration, enabling them to work effectively with reduced adverse effects. In addition, supportive drugs have successfully appeared. For instance, antidepressants such as TCA, SSRI, and SNRI have been shown to be effective for difficult pain. Neuropathic pain was eased using specific drugs such as pregabalin. The amount of opioid drugs can be reduced using these different drugs. Moreover, opioid-induced adverse effects, especially constipation and nausea, can be treated using specific methodologies. Thus, the opioid can be used safely and effectively than before. In this study, such developed drugs and methodologies were applied for all participants. USCPN was performed for half of them who were randomly allocated to the subject group. The pain intensity at week 4, which was defined as the primary endpoint, was similar between the groups with and without EUS-CPN. Pain intensity at other evaluation times, that is weeks 1 to 8 and 12, were similar between the groups. Moreover, opioid consumption and survival period were similar. We did not detect any differences between the groups. Of course, in theory, the lack of statistic differences does not prove similarity. However, if there is a difference with a very wide margin, statistics could indicate the difference. A small difference could actually be overlooked. Moreover, you can find this study involved a relatively small population, 24 patients in each group. Furthermore, the population number dwindled to 17 in the EUS-CPN group and 19 in the control group for week 4 analysis. This is the main weak point of our study. It may have resulted in a lack of power to detect differences. However, we can say EUS-CPN does not have overwhelming power to remove pain or reduce opioid usage. EUS-CPN does not seem appropriate for all patients with pain in an early clinical phase. For EUS-CPN to have exceptional value, pain intensity or opioid consumption must have been different by a wide margin, with even such a small sample size. Average pain intensity was rather much smaller for control patients in most evaluation timings, although it did not have statistical significance. Given the similarities in the adverse effects, EUS-CPN should not be performed for all patients. I don't mean that EUS-CPN is useless. It would be effective and possibly very useful for some patients. The purpose of this study was not to evaluate which patient would be benefit from it or what situation is suitable for it. These points must be confirmed in other future studies. This study was only concerned with whether or not EUS-CPN is worth performing to treat all patients with pancreatic cancer pain. From our study, we cannot discuss whether or not EUS-CPN should be performed, but I would like to express my opinion. EUS-CPN can be useful for patients with intolerable pain that was not relieved by opioids. We often experience cases in which EUS-CPN drastically works for pain that becomes uncontrollable using huge amounts of opioids. Moreover, cases with severe adverse effects from opioids are good candidates for EUS-CPN. Nausea, belching, appetite loss, constipation, and illness like bowel hyperperistalsis can be improved by performing EUS-CPN even if the cause of the symptom is difficult to link to cancer advancement or opioid effects. Meanwhile, I think that patients with mild pain, those with pain control using opioids, and those who are not hospitalized should not undergo EUS-CPN. Moreover, we should take into consideration the patient's intolerance to alcohol and a tendency towards diarrhea. What's more, it may be important to weigh the difficulty for frequent hospital visits and financial status for expensive drug purchases, which may be related to outcomes, as Dr. WYSE'S report indicated.